guess the other point is if we are using conventional imaging, then probably we're going to see PSAs rising. Let's say someone's on doublet therapy, metastatic hormone sensitive. PSA is rising, but usually those conventional scans aren't going to change. So when do you decide someone's really, really castration resistant to the point that you want to change therapy?
Can I just say something? We're about to publish with Dan George and others data showing that people that have been on ADT and an NRP and have a PSA of 0, still 20% of them on conventional imaging will have disease. So you can't just sit back, even if the PSA is 0 on those patients. You need to do conventional imaging to find disease.
How frequently would you recommend?
No, like once a year.
Once a year, yeah, that's what I do when PSA is down, but when PSA is rising, I do it more frequently.
That's different, obviously.
Yeah, we've done the same thing at Mayo. I mean, we've looked in the setting of PET scans, how often do you have disease progression in the setting of PSA 0, right? Mm-hmm. And it was a very similar number using the historic choline database that we have. About 20% of patients will have disease progression at undetectable PSAs. And Jack Andrews right now at Mayo, Arizona is working on the same thing, PSA 0 progression with PSMA PET scans. I struggle a little bit with using PSMA PET scans for surveillance. I agree with you guys that the data doesn't exist right now, but it feels a little funny to order scans that none of us think are the best scans for finding disease. And I heard somebody at this meeting refer to conventional imaging as vintage imaging, and I don't know that I want to be a vintage doctor using vintage imaging. I want to be using what we think is the best imaging modality. And if you're a believer in metastasis-directed therapy, and I'm a believer in metastasis-directed therapy, I want to use the scan that's going to find the most amount of metastasis on, follow-up imaging. I think there's going to be something, we're not there yet, but I think there's going to be something to finding oligo-resistant clones and eradicating that clone that might delay the onset of castration resistance. So I don't know, I think it's an exciting space, and I don't think our practices 5 years from now will be like they are right now using conventional imaging.
I think even if it doesn't delay castration resistance, I think as castration resistance emerges, and Howard Scher published on this some years ago in the context of enzalutamide, I think it must have been in CRPC, with PSA rising, imaging's not changing, and then there is radiation to an oligo progression and PSA drops, and you can sort of maintain that therapy. So as patients are getting doublet in mHSPC, that is something I'm doing, but interestingly, I think I am doing it with conventional imaging rather than PSMA PET. But I think there can be clonal differences in a single patient, differences among their tumors.
I will make a plug. I think that, we have put a plug in for Chad Tang, who gave a presentation here. He has an extend oligo progression trial, but I do think that trials are needed here. We do act like doing metastasis-directed therapy is harmless. It's not. You can have you can have downstream fractures, you can have other complications of radiation, and I think the question that we're all asking is, if somebody has an oligo progression, less than 5 lesions progressing, is there benefit from metastasis-directed therapy in lieu of change of systemic therapy? And we don't know. I don't think that data exists in the PSMA PET era, and it's going to be really provocative. I do agree that within 5 years we're going to have data. Everyone's doing it. I mean, we're all adopting it pre-trial, but I do think that put a plug in for getting higher level evidence to guide everybody.
Yeah, certainly we should be doing it on trial, because that's how we'll learn how that compares to other approaches, such as switching to some of the newer agents. So as we start to wrap up, I'd love to hear from each of you maybe what was most interesting at the GU ASCO meeting for prostate cancer.
I think the TALAPRO-2 data was extremely interesting. I don't know that I'm necessarily going to follow and just treat everybody without doing genomic testing. I agree with you on that, but I think that the data was absolutely very interesting with enzalutamide and talazoparib for practically everybody. But I think that I'm still going to do the genomic testing, and the people with HRR abnormalities, I'll consider giving a PARP inhibitor. I don't think that in my practice I'll be giving the combination, because patients are already on a combination before they start.
Yeah. I'll tell you, I get most excited walking down the last row at ASCO GU each year, where they're talking about the trials in progress, all those posters, right? And when we see molecular strategies in the hormone-sensitive space, when we see all the radiopharmaceuticals that are in development for CRPC, not just in targeting PSMA, but other cell surface markers, that's what gets me excited every time I come back.
Nice. For me, it was that surprising sort of presentation about in the definitive setting where we're using defined course of hormone therapy, that testosterone recovery was associated with better survival than men who don't recover their testosterone regardless of the duration of hormone therapy that was administered. And I think we just need to pay more attention to testosterone in our practices and how it impacts prostate cancer as well as overall health.
I agree with the TalaPro-2, but just to try to add something else, I'll say Dr. Schweitzer presented the EZH inhibitor from Pfizer, and it was provocative. It's early phase data, but against Enza, adding it to Enza, hazard ratio of 0.5, so a 50% reduction in the hazard for disease progression. So provocative. I think it's moving on to later lines, but I think that's going to be interesting to watch.
And it was MCRPC in the context of prior AR pathway inhibitor, unlike TalaPro-2, which maybe will make it more relevant. And that's a target that we've been looking at for a long time, that EZH2. So it was nice to see that come to fruition.
And typically a very well-tolerated medicine. I don't know that one specific, but when we've used EZH inhibitors, they're typically very well-tolerated. So excited to see it develop.
Yeah.
Well, at the risk of being repetitive, I'll wrap up with TalaPro-2 as well, because I thought that really was the big presentation probably at this meeting in prostate cancer. I think it's really provocative data. It's really interesting that in the all-comers, right, you see the benefit, I think, of this combination. But I don't know, I wonder rather about our ability to really adopt that data. I don't know that we'll be using, that's just my take on it. I don't know that we'll really be using this combination in a lot of patients for, a variety of reasons, in part because we don't see this population as much, at least at academic centers, right, because most of them would have been exposed to an ARCI already. And then also, of course, concerns about toxicity and whether, you really would get significant benefit in a non-HRR patient. So, but it's really interesting data, and it was really interesting to see it.
Yeah, and AR pathway inhibitors are moving into the biochemical recurrence space with trials like EMBARK. They're moving into salvage radiation space in some trials, not yet for practice, but in trials. And so, I feel like there are just going to be more and more patients who will have had significant exposure to AR pathway inhibitors over time. But overall, I think, we have to remember that every patient's different, every patient's journey is different. It's great to have options, and then we can use genomics, use imaging, and try to make the best decision for every patient. So thank you so much for all of your insights. It's been a pleasure speaking with you today.